we've got two speakers presenting the next topic, both Ben Rapoport and Ian Odland, a medical student working in Sinai BioDesign. Starting with Ben, everybody here knows him well. He's presented in Grand Rounds many times, and his list of degrees is too long to read in this setting, but he is an expert in bioengineering. That's what his PhD was in at MIT, and he's the director of Sinai BioDesign, where numerous exciting projects are happening. And he's going to talk to us about one specific project, developing a pathway for embolization of meningiomas. And let me give a little bit more detail for Ian Odland. For those of you who don't know him, he's a rising fourth-year medical student at Mount Sinai. He's doing a scholarly year with us in Sinai BioDesign, focusing on artificial intelligence algorithms and device development. The main project he's been working on with Dr. Chowdhury is a steerable screwdriver for A-lifts. And for this, he's won numerous awards, including the MSIP I3 Genesis Award, also an NSF National I-Core grant, and a Trainee Innovation Prize, and an international patent application. So already has a lot of success in the device development space. And he came to us with some experience prior to medical school. He had worked in two different startups. And as you can see, he's also a marathon runner and giving Ben a run for his money, I understand, when in his projected times for the Paris and Chicago marathons upcoming. So looking forward to hearing your talk, guys.
Terrific. Chris, thank you very much for the warm introduction. Let me just, can I confirm that my audio is working okay?
Yeah, sounds good.
And then let me share screen. Is that projecting all right in projection mode?
Yep.
And screen's not obstructed?
It's good.
Terrific. Thank you. Thanks for having all of us. And actually, I'm going to share this presentation not only with Ian Odland, who, as Chris mentioned, is doing his scholarly year in the department, and with Chris and myself and Dr. Chowdhury as mentors, but also with Rui Feng, who many of you know is our esteemed chief resident going on to a skull-based fellowship. So I'll be presenting a portion of the talk, and then I'm going to share the floor with Ian and Ray for the portions that they've done. And just a quick disclosure that this presentation will cover some of the novel work that we're doing in BioDesign in collaboration with Dr. Berenstein, Dr. Bederson, and Munir Ghassani in developing a new embolic agent. That'll be a small portion of the talk. And I really want to start with the thanks, because this work that we're going to be discussing today on meningioma embolization has spanned a huge collaboration across our department in cerebrovascular and skull-based neurosurgery, endovascular neurosurgery, and across collaborating departments, including nuclear medicine, neuroradiology, neuropathology, and the graduate school in the areas of artificial intelligence and emerging technologies. And so many people have been involved on the clinical side, and also among the residents and fellows and medical students. And I think hopefully you'll see the reason for the extensive teamwork required here. And I think it's a strength of our department that we were really able to carry out this work, which I think couldn't be done without really close collaboration and very respectful interactions across disciplines that are sometimes not in such good communication. And this work has moved forward really thanks to that amazing collaboration. I also want to acknowledge that meningioembolization, tumor embolization in general, has a long history. Dr. Berenstein likes to remind me when we discuss this that he was embolizing meningiomas long before I was born. So we definitely did not invent what we're discussing today, but I think we've contributed to it in a number of ways, and I'm looking forward to sharing that. I'm going to show this case, which in my personal experience was my index case with not with tumor embolization, but with the paradigm that we're going to discuss today, i.e. that meningioma embolization is not just about devascularizing tumors, but that it can really impact the technique used for surgical resection through biological changes in the tumor that can affect the manner in which the tumor is resected and the way it handles at the time of surgery. This was a case that I did as a chief resident. I did the embolization in the IR suite, and my co-chief resident did the resection. And what happened was this was kind of an accident. And I want to highlight this just as an example of the ways that sometimes, a particular case can accidentally impact your career, especially for the residents. This was a woman of around 80 years old who had come in for treatment of this meningioma, sort of lateral sphenoid wing convexity meningioma, for elective treatment. And she had come in on a Thursday for embolization with anticipation of resection the following Monday. So we did the embolization as planned, and she stayed over the weekend, which is usually we wouldn't nowadays schedule things in that manner. Usually nowadays we usually do the embolization a day or two before surgery. For whatever reason, logistically, the scheduling happened to work out in that way. And so the embolization was done on a Thursday, and then she had a presenting MRI long before that, and then she had a brain, which is what I'm showing on the left-hand side, 5 or 6 centimeter meningioma with significant mass affected midline shift, and then she had a brain lab preoperative MRI the day of surgery, which was Monday, and you can see a dramatic change in the MR characteristics of the tumor in that 4 to 5 day period. And my co-chief resident called me into the operating room and said, "You got to see this. The tumor was completely liquefied." And of course, the whole nature of this problem is that it's hard to know what a control is, because these patients either get embolized or don't, and you don't always have such an easy time understanding what the impact is of the embolization. And that's the whole essence of what we're going to be discussing today. But that set in my mind in motion this process of, can we better understand what's going on with embolization? What are we doing to the tumor besides devascularizing it? And can we understand that better with a view towards more minimally invasive treatments and more safe treatments? So that's just a high-level background for what's coming next. And this talk is divided into 8 parts, and we'll try to move through them efficiently as we share the floor, the 3 of us. Part 1 is about what seems to happen when a meningioma is embolized, both technically and from the standpoint of the evidence that exists in the literature. Part 2, we'll talk about the question of efficacy of embolization, and in particular emphasizing the work that we've done over the last 4 years as a collaborative group, especially going beyond the concept of measuring blood loss, which is what the literature really has focused on, the impact of embolization on blood loss at surgery, and moving more towards the kind of oncologic concept, borrowing from the concept of extensive resection, which we're so familiar with in the neuro-oncologic world, and moving towards a concept which we'll show you of quantitative extensive embolization that we've developed and now published on over the last few years. Then we'll look at a systematic analysis of the Mount Sinai experience over the last basically decade, retrospectively, and through a careful systematic analysis of essentially all of the consecutive cases that we've logged, we've been able to address some issues, some questions about what is the optimal timing between embolization and surgery, how do tumor skull base anatomy and the vascular anatomy that feeds the tumors impact the efficacy of embolization and the outcome at surgery. We'll talk about complications and these questions of how does embolization affect edema, and is that a concern in the postoperative management of these patients. We'll talk a little bit about the impact of tumor type, but more specifically, I'm going to hand the floor to Ian to discuss the digital pathology workflow that has been put in place at Mount Sinai, and the ways that has enabled us to implement machine learning paradigms in analysis of these tumors. And finally, we'll talk a little bit about novel embolic agents. I'll discuss our work on developing kind of an atlas of meningioma embolization from the 170 odd cases that we now have analyzed. And then we'll talk a little bit about implications for more minimally invasive approaches to treatment of meningiomas, including both the potential to use keyhole approaches for well-embolized tumors and what's coming next, which is a registry of prospective embolization alone as a possible standalone treatment for meningiomas. So just quickly, what does the embolization procedure look like? So here's a lateral sphenoid wing meningioma. We're all familiar with such cases. This is the presenting MRI for one such case. When a tumor like this goes for embolization, we perform an initial diagnostic angiogram, and very often these meningiomas have an external carotid supply. Some of them also have an internal carotid supply, and of course, it's only safe to embolize the external carotid feeders, and the control angiogram is used to define those. And then we can selectively catheterize with the microcatheter the external carotid feeders to the tumor. And here on the lower panels, you see the very characteristic avid tumor blush from branches of the middle meningeal artery supplying the tumor. And using that same microcatheter, we can inject embolic agents into the tumor to stop the arterial blood supply to the tumor in a way that's super selective and impacts only the tumor's blood supply, but obviously not any PL collaterals or intracranial collaterals to avoid any neurologic complications. That's the essence of the tumor embolization procedure. And then, as you can see on the follow-up angiogram, there's a characteristic loss of tumor blush. And so here, especially in the lateral angiogram, you can see that what was that tumor blush that was present in the control angiogram and at the time of microcatheter injection is completely gone in this setting. And so we would call this a complete angiographic devascularization of the tumor. And we'll get into what that actually does to the tumor. There is a huge body of literature on going back and forth over the last several decades on what is the impact of embolization on meningiomas. And that has given rise to a fair amount of debate in both the cerebrovascular literature and the skull-based literature on when to use embolization and whether to use embolization. And in all of these cases, almost all of these cases in the early literature, the variable that was addressed was intraoperative blood loss. And hence the difficulty of finding an effect, because as we all know, intraoperative blood loss is notoriously difficult to manage, especially if the measurement is based on estimated blood loss. Sometimes that ends up being a random number almost, and very often, even when it's well measured, the blood loss is predominantly from the approach and not necessarily just from the tumor resection. And so that's maybe not the right parameter to measure. There is a fair amount, a small literature looking at other aspects of tumor embolization, and some of the reported benefits include tumor necrosis, softening the tumor or liquefying the tumor at the time of resection. And those of us who do the surgeries have all experienced that in a subjective fashion. And it's been part of our project to find objective ways to measure and assess that impact. There's been studies looking at reduction of intraoperative complications following embolization. There's been studies looking at reduction of operative time when large meningiomas have been well embolized. And there's one recent study that suggests that there's a longer time to meningioma recurrence in tumors that have been embolized. On the downside, we all know that some of these procedures, have been associated with complications, and we've quantified that very well in our series. And then of course there's the questions of cost of an additional procedure. All told, in the literature, at this time only about 2 to 3% of meningiomas are embolized. So there's a question of which are the right meningiomas to embolize and how do we select them to benefit the patients and the surgeons. I'll give a spoiler alert here at the beginning, which is that last year we published the first of 2 papers coming out of the Mount Sinai series. As you can see, the author list is about 25 authors and represents colleagues from our department across both cerebrovascular and skull-based services, and includes a number of residents and fellows and pre-residency fellows. And part of what we did, which we'll describe later on, is to introduce a grading system to more objectively assess the angiographic results following embolization, and to correlate that with volumetric analyses of the MRIs using our extent of embolization based on kind of the concept of extent of resection in tumor surgery. And and we've shown significant impact, and we've started to narrow down which are the tumors that respond best to embolization. So looking back at that same sphenoid wing meningioma that I showed you before, that lateral sphenoid wing meningioma. So here's the preoperative MRI and the treatment angiogram. You can see again the initial tumor blush, the injection at the time of embolization, and then on the far right, loss of tumor blush on the lateral angiogram. And now here's what the MRI looks like after embolization, but before tumor resection. And this was an innovation that we put in place starting in 2021 when we formalized this retrospective study. It was a very small innovation, but an impactful one, because one of the reasons that it's been so hard to study meningioma embolization is because it's been hard to isolate the impact of embolization from the impact of surgery. And in most centers, even today, the imaging studies that are done are at the time of presentation. So before any treatment, the standard preoperative or pre-treatment MRI is done. And that, of course, happens both before surgery and before embolization in the case of tumors that are going to be embolized. And then another MRI is done sometime after surgery, which means after surgery and after embolization. And so it's been hard historically to isolate the effects of embolization from the effects of surgery. And so we introduced another MRI study after embolization, but before surgical resection, so that we could identify the impact of the embolization as distinct from that of resection. And what we find is that after embolization, there is a reduction in the degree of contrast enhancement in the tumor. And that was initially just an observation, and you can see that that's a dramatic effect in this particular case that I've chosen on the post-embolization but preoperative MRI. This tumor has almost completely lost its contrast enhancement. So that is a post-contrast scan in the top right there. But the tumor has been extensively embolized, and the observation that we found early on was that in the well-embolized tumors, there was a significant loss of contrast enhancement, and the hypothesis was that loss of contrast enhancement corresponded to the area that was devascularized by the embolization. And so we sought really to try to study that in a systematic way. I want to give you a little bit of intuition for the impact of embolization when it works well on surgical resection. So here is a follicine parasagittal meningioma. This was embolized through the bilateral middle meningeal arteries. You can see here with the NBCA glue on the anterior and lateral angiograms. You can see in the lower right-hand corner the glue casts on the AP fluoro shot at the end of the case. And so again, in the top, you see the preoperative, pre-treatment, pre-everything MRI. And in the bottom panels, axial, sagittal, coronal, you're seeing the preoperative but post-embolization scan. So here again, you see just about 90% loss of contrast enhancement. So again, it's a post-contrast scan, but something clearly has happened to the tumor. What is that? And if you look back, you can see that that area of loss of contrast enhancement really corresponds, at least subjectively, to the area that's devascularized by the angiogram. And what do we find at surgery? So when we open up the tumor, when we cut into the tumor capsule, this tumor looked, I like to call it marshmallow fluff. This was a very well devascularized tumor. As many of you know, the meningioma, before it's devascularized, typically looks sort of purplish and a little bit hemorrhagic, depending on the consistency. And there's obviously some variability, but something has happened to this tumor that is not normal, right? And this is what we find when a tumor has been embolized well, that it's soft, suckable, and white with the consistency of a kind of marshmallow fluff. And to give you maybe a little bit more intuition, I'll play a video. You may hear Raj and me and one of the prior residents chatting in the background here. But so we've just, I think this is Raj has just cut into the tumor capsule, and here's the ultrasonic aspirator just this entire tumor, you can see, aspirates very, very easily. So this kind of embolization, that gray area, for those of you who are not familiar, is the embolic cast of the larger feeding arteries, and this is a piece of the resected tumor, resected pathology. So that certainly, when it works well, facilitates the resection in a significant way. So how do we get quantitative about this and go beyond observation to something more rigorous? And importantly, what is an appropriate control? Because it's very hard to know. You only do the surgery once. It's very hard to know what the tumor would have looked like if you hadn't embolized it. This is a kind of thorny problem. And what are the factors that affect effective embolization? And there are quite a few. Those include tumor location, the vascular anatomy of the tumor, some aspects of tumor biology, the embolic material and the technique of embolization, and then, as we mentioned, the timing between embolization and surgery. And in the subsequent sections, we'll touch on most, but perhaps not all of these topics. So to spend a few minutes on the vascular anatomy and its impact on the potential to embolize a particular tumor. And I'll do this in a systematic way later on, but I just want to give a little bit of intuition up front. So here's a different tumor, okay, a convexity meningioma. And here's the control angiogram. And you can see that this tumor has both internal carotid and external carotid supply. So there is a portion of the tumor, the more superior aspects of it that are closer to the convexity, that are supplied by external carotid feeders. And then you can also see that there is a peel collateral supply from internal carotid feeders, and the yellow arrow points that out, that there is a portion of the tumor that is against the peel surface that has a peel collateral supply that has MCA feeders, and that portion of the tumor is not safe to embolize, for fear of causing a stroke, obviously. And so the following post-embolization MRI is going to show a very good correspondence between the area that was supplied by the external carotids, which we could embolize, and the residual area that was not embolized that continues to enhance, that corresponds to the peel collaterals. And you can see that here on the right-hand panels, that the area that has lost contrast enhancement on the post-embolization scan, the dark area, that was the area with the middle meningeal supply, and the peel collateral supply makes that deeper area of the tumor, in this particular case, not suitable for embolization. So that's the intuition that I would like to provide, and we'll make that a little bit more rigorous subsequently. Here's another example, and this for anterior fossa and medial sphenoid meningiomas is, I think, a key anatomic point to understand, that there is a very important anastomosis that I think all of us are familiar with between the ophthalmic and the middle meningeal arteries. And tumors in this general area, anterior fossa, anterior middle fossa, sphenoid meningiomas, they take their vascular supply sometimes from the middle meningeal, sometimes from the ophthalmic, and almost universally from some portion of that anastomotic network. And so the degree to which these tumors are safely embolizable really depends very heavily on to what extent is there internal carotid supply with ophthalmic supply, and to what extent is more of the tumor supplied by the middle meningeal. And in this particular case, it's sort of half and half. And the result is that you can get about a 50% embolization through the portion that's safe to embolize. And this is a theme that will emerge as we develop the atlas of tumor embolization, and you'll see that later on. So we then performed an extensive retrospective analysis of the Mount Sinai experience, and that has allowed us to really rigorously answer a number of questions. Can we define efficacy of embolization in a rigorous way? Can we define which patients and which tumors are most suitable and benefit from embolization? Can we identify the factors that contribute to that with respect to tumor location, the arterial feeders, tumor size, embolic materials used? Can we figure out what the optimal delay is, if there is one, between embolization and resection? And can we really quantify the complication profile and push that down as close as possible to zero? And again, I'm just going to thank here the army of people that's been involved in this work. We've now retrospectively reviewed between 2016 and 2024 more than 170 consecutive meningioma embolization cases. That has allowed us to really develop an atlas of meningioma embolization. So we've published on part of that, and the work continues, and that has included a number of residents, including Halima and Ray and Brandon and others, a number of really talented medical students, including Ian and Lily and others, and some of our pre-residency fellows, including Stavros Matsoukas, who was the first author on one of the papers published last year, and one of our biomedical engineering PhD students who graduated last year, Denzel Faulkner. And we've now also analyzed 75 and counting consecutive patients in this 3 MRI series. So not all of the patients between 2016 and 2021 had that third MRI, but almost everyone has one. I think almost everyone, almost without exception, has one now, and we do about one of these cases per week. So how do we get rigorous about quantifying the angiographic impact of the embolization, and how do we correlate that with the MR findings? So this was really a two-step process at the beginning of this project. One was, historically, we rely on the proceduralist performing the embolization to give a subjective and qualitative interpretation in the radiology report of what happened after embolization, and usually that amounts to some comments about the reduction in tumor blush following embolization, or that safe embolization was not possible due to the nature of the feeders. And so we sought to put in place a grading scale that formalized that, which I'll show in the subsequent slides, and then to move from that grading scale to make a correlation between what we see on the angiograms and what we see on the post-embolization MRI to really formalize this notion of extent of embolization, and to kind of make the connection between the cerebrovascular side of things and a more neuro-oncologic framework. And to just to give you a preview of what we developed, we really were able to show consistently that the angiographic grading scale correlates very well with the MR extent of embolization measure. But here's the scale. I won't belabor it, but just to show that it exists. And like all scales and grading schemes, it's subject to some debate as to why the scale was put together in this way. But you'll see it makes intuitive sense with some room for debate. So a grade 0 embolization corresponds to the cases that we bring to the angio suite with intention to treat, but then find that all of the feeders are either not catheterizable, or they all come from the internal carotid artery. A grade 1 embolization is a case in which we embolize but accomplish only less than 50% tumor blush reduction. A grade 2 is 51 to 99% reduction in tumor blush. Grade 3 is like the case that I showed earlier on, where we can completely embolize the external carotid feeders, but there's residual internal carotid supply. And a grade 4 embolization is a complete reduction in tumor blush, like the first case I showed of that lateral sphenoid wing convexity meningioma. Okay, so and then we also formalized the volumetric analysis of the loss of contrast. So I showed a couple of examples in which we have a post-embolization preoperative MRI in which there is a clear chunk of the tumor that has now lost contrast enhancement. And because these scans are all brain lab volumetric scans, we can do a voxel by voxel volumetric analysis of what portion of the tumor has lost contrast enhancement. That allowed us to define this extent of embolization metric. And again, to just give you the punchline first, we found in the first 30 patients that were published on, and this has been more or less consistent in subsequent analysis of the total group of 75, that the average embolization extent of embolization is about 40%, 38 plus or minus 6%. But there's significant variability that goes all the way from almost zero or zero to almost 100%. And trying to predict which tumors are going to respond well has been a big portion of this project. This analysis is due to Denzel Faulkner, the biomedical engineering PhD student I mentioned earlier, who was working with us in BioDesign for a few years. And I just want to show a couple of screenshots to give some intuition for how this pipeline works. So now we have a formal pipeline for doing this volumetric analysis. We can basically segment out the tumor. We can use the post-embolization preoperative MRI to segment out even quite complex shapes of tumor that have lost contrast enhancement and those that retain contrast enhancement. And those are the areas that we call now. I want to be careful about what's proven and what's hypothesis still, but what we call embolized and non-embolized tumor. And you can see that varies all the way from, for example, in this case here, which I showed earlier on, just a 91% volumetric embolization. Here in this parasagittal falcine meningioma supplied by the metameningeal, a 60% volumetric embolization, and here in this tumor with significant ophthalmic collaterals, only a 30% embolization. So, but we had thanks to just an incredibly high volume, very productive service, we now have, as I mentioned, 170 and counting consecutive cases, and that has allowed us to build kind of an atlas. And some of these anecdotal cases that I've shown you to build intuition, we've been able to formally analyze with good statistics and to answer a number of questions. So I won't go through the tables, but just to sort of highlight, tumor location and arterial supply, as you would expect, are tightly coupled. So convexity meningiomas, for example, as you would expect, are typically supplied by metameningeal, and so they're more easy to embolize more completely. Sphenoid wing meningiomas, depending on where they are on the sphenoid wing, as I mentioned, sometimes have a more metameningeal supply and sometimes have a more ICA or ophthalmic supply. So those are some of the highlights to take away. And some of the very medial meningiomas, for example, the clinoid, clival, or medial sphenoid wing meningiomas, take a supply from the intradural internal carotid artery, so the meningohypophyseal trunk, infralateral trunk. So those are often, they're either very hard to or unsafe to catheterize. And so those meningiomas often don't get embolized. Location and arterial supply, obviously, maybe not obviously, but that do impact efficacy of embolization. So as I mentioned, those that are convexity, lateral sphenoid wing, and others tend to be more easy to embolize completely. And for example, those that have a ILT or MHT supply can be very difficult to embolize. And tumor location predicts efficacy of embolization. Okay, I'll show some of these. And we were able to quantify this. And the statistics are sometimes intuitive and sometimes challenging, but we're able to do this really very carefully with the help of biostatistics here at Mount Sinai, with particular help from John Durbin, who's a PhD student with us in BioDesign in the population health department. And I want to highlight a few findings. So for example, here on the bottom, you can see that convexity versus non-convexity location confers grade likelihood of a good embolization. Okay, can you still hear me okay? So if you have a convexity versus non-convexity meningioma, you're likely to get a 1 grade better embolization. And anterior midline versus non-anterior midline. So for example, those tumors that are clival or clinoidal are much less likely to get a good embolization by 2 vascular grades. Okay, and we can perform similar analyses based on the tumor arterial supply once we have the control angiogram. So we've published on all of these findings last year. I want to turn the floor over for a few minutes now to Ray and Ian to discuss their portions of the study. Ray has done an incredibly diligent analysis of tumor edema, and I want to let her present that, which has been a really big open question in this field for some time. And then Ian's going to present in a few minutes what has for us been an exciting next move in this work, which is to move from angiography and radiology into the world of pathology, digital pathology, and machine learning to dive a little deeper into the mechanisms by which we're impacting the tumors. So Ray, can you present your portion?
Certainly. Thank you so much, Dr. Rapoport, and really appreciate your guidance throughout this project. But yeah, this stems from a clinical concern that I do encounter. I realize as I go to different courses throughout the country for skull base, there's a wide range of practice of how people treat these tumors. And every time I bring up, does your department do preoperative embolization? A lot of the times, the surgeon will say, no, because we have a pretty high concern of the tumor acutely swelling, the edema acutely increasing, and we want to avoid the need of urgently having to take the patient to the OR for decompressing the tumor in an emergent manner. So it's definitely not a standard of practice, but nobody's really able to say like what exactly is the complication rate of these things happening. Is when we look into the literature, it seems like this effect is extremely rare, but there's quite a wide range from less than 1%, sometimes to up to 15% in the old literature. Again, we have no idea if that it's related to timing, that's related to technique, if that any of that is related to even embolic material. So this is what we did. Like Dr. Rapoport described before, we developed a pipeline of first of all, getting that extra MRI scan in between the embolization procedure and the surgery, and looking at the total volume of the tumor and segmenting it out to obtain an accurate 3D volume rather than the traditional 2D simplified measurements. And also taking a 3D volumetric measurement of the surrounding brain edema. And then we compared the size of the tumor prior to the embolization procedure and post-embolization. And then we've done similar analysis for the edema volume. So for this portion, for now, we only included 28 patients, but we do have the data gathered for our full set of 70 plus, and that analysis will be completed very soon. But from our preliminary analysis, you can see that we had a range of embolization extent, but a significant portion of these patients have received embolization extent of over moderate to high extent. And the mean tumor size we calculated, and it is not statistically significant when it compares to post-embolization. So there's only a small portion of the patients that had an increase, but most of the patients actually experienced a decrease in tumor volume. And going on to embolization edema, there's also not a significant change in the edema index pre-embolization compared to post-embolization. Most of these patients, their edema index remain unchanged, and only a small portion that had the increase and another small portion had a decrease. Through our analysis, we were finding that the change in edema index was not significantly correlated with embolization extent, as some providers have concerns over, or neither is it related to pre-embolization tumor volume. However, the data point that came out as statistically significant is that the change in edema index is correlated with pre-embolization edema index. So there is a potential correlation that for patients with higher amount of edema to begin with, they potentially are at more risk for swelling even after the post-embolization procedure. Again, full analysis are our 70 plus patients is in process, and hopefully with a larger patient volume, we're able to elucidate these factors even more.
Thank you. I think more on this in the future as we extend to longer timelines between embolization and resection. I just want to spend a second on complications because we definitely can't overlook this. But at this point, we've extensively looked at the complications, the complication profile in tumor embolizations. It's not uncommon for patients to have post-embolization headache, but beyond that, we've only had 2 cases of cranial nerve dysfunction and post-embolization, and 2 cases of post-embolization preoperative seizures. There have been no large or symptomatic ischemic events detected in the post-embolization preoperative MRI, and I would say that that's one of the major benefits of doing the post-op MRI. We've been able to post-embolization MRI. We've been able to say really definitively that the ischemic burden is negligible, and Ray spoke about the edema changes and tumor size changes that we're seeing in the small interval that is typical, time interval that's typical in our case series between embolization and resection. I now want to give the floor to Ian Odland to shed some insight into the correlation that we've begun to show between what we see on imaging and what we see on histopathology. And this has really deepened our understanding and intuition for the biological impact of embolization on tumors.
Yeah, thank you, Dr. Rapoport and Ray, for including me in this project. I've really appreciated learning and kind of how intentional this research effort has been throughout the process. And I'm excited to keep on working together. So our next steps are focused on understanding how do the radiographic findings correlate with the operative and histologic findings. The MRI on the left demonstrates a significant volume of non-enhancing and enhancing meningioma. And this correlates with the intraoperative findings of, to use a technical term, marshmallow fluff when prying through the tumor. It is important to further examine these changes at the histological level in order to understand meningioma response to embolization-induced ischemia. We've partnered with Dr. Melissa Umflett and Dr. Raquel Yakota from the Department of Pathology, as well as Jason Chen, Dr. Ruchika Verma, and Dr. Gabrielle Campanella from the Wingert Department of Artificial Intelligence, and amended our study protocol to enable navigation-guided biopsies of the embolized and non-embolized regions of the tumor in order to perform separate histologic analysis on digital pathology. Next slide, please. In 2021, Mount Sinai implemented a process to allow digital diagnosis and machine learning analysis technology to pathology specimens. This offers a more rigorous quantitative approach to assessing histological changes. In this slide, we're able to review the workflow of taking biopsies from OR to digital upload, which is pretty novel compared to most health systems across the country. Specimens are transported from the OR to the Department of Pathology, where they are closely tracked with accessioning. There, the gross specimen is oriented and divided into smaller sections and placed in labeled cassettes. The specimens are fixed in formalin and embedded in Paragon on a tissue block, and then can be sliced using a microtome, stained in H&E, and digitally scanned and uploaded to PowerPath, which is the Department of Pathology's equivalent to PACS. Next slide, please. Owing to this process, we're able to retrospectively query digital histology specimens from past cases. Through working with Dr. Campanella's lab to identify and analyze all 175 tumor specimens that underwent preoperative digital subtraction and angiography since late 2015. The workflow starts by using the AI-ready Mount Sinai platform in order to query clinical data for data science and AI ML use practices. We then select patients who have a digital specimen listed with the correct acquisition date and are H&E stained. And then we can determine if these scans have been uploaded to PowerPath. I want to stress the fact that any studies before 2021 are not likely to have been uploaded. However, we can retrospectively upload them with the help of our collaborators at the Department of AI and ML. Finally, the slides can be queried on DataArc, which is the data commons of Mount Sinai's AI ML supercomputer known as Minerva. And through this process, we've been able to successfully identify 61% of the histology slides from our cohort, and we're working actively to increase that amount with Dr. Campanella's team. Next slide, please. So hypoxic ischemic changes in the brain have been more extensively studied within the context of stroke. And I think this is especially important to note that ischemia in the brain is unique compared to other organs because instead of undergoing coagulative necrosis in response to an ischemic insult, the tissue undergoes a liquefactive response. Within 48 hours of insult, the neurons begin to shrink, the tissue becomes grossly more eosinophilic, and neutrophil invasion contributes to inflammation. In the following 2 to 3 days, monocytes and microglia arrive and begin clearing debris, and there is overall release of lysozyme and other lytic material that further breaks down local tissue. Between 7 and 21 days, reactive astrocytes and newly formed microvessels are visible at the periphery of the lesion. And a few months after the stroke, there is notable decrease in brain volume, and you are able to see the form of a glial scar. The differences in how meningioma tissue responds compared to healthy tissue to the ischemic insult carries major implications for the determination of this embolization resection interval and the efficacy of standalone tumor embolization. I mean, I have a whole host of questions that kind of stem from just taking into account the pathology. Does tumor resilience to hypoxia slow the progression of necrosis? Does angiogenic factor production from the tumor result in faster capillary formation following embolization? And is it possible to delay the resection a few months in order to approach a smaller, more easily resected meningioma? Next slide, please. With all these questions in mind, I want to return to the previously embolized meningioma histology sample. This patient here was treated in 2022 and had a grade 3 devascularization on angiography, resulting in a 55% MRI enhancement loss, with gross total resection achieved on post-embolization day 7. If you start looking at this image and look to the lower left corner, you can actually see the onyx glucast within the middle meningeal artery. And directly below that, you can kind of see a breaking point between more eosinophilic pink pale tissue on top and more basophilic tissue below that. Based on the progressions that are seen within brain tissue experiencing ischemia, we're hypothesizing that this might be the distribution of the middle meningeal artery versus other arterial feeders within this tumor. Our next steps will involve applying hypothesis and data-driven AI/ML techniques in order to quantify markers of hypoxic ischemic change, such as cellular density, pallor index as a marker of the overall coloration, the amount of eosinophilia versus basophilia, the microvessel density, the intratumoral edema, and mitotic index. We then hope to correlate these histologic findings with the radiographic and operative findings, such as the length of that interval, the amount of tumor edema, and the amount of enhancement loss on that pre-resection post-embolization MRI.
Awesome. Thanks for presenting that. And I think the next time we show some of this work, inevitably we'll have more to say about the histopathology. And I just want to take a second to acknowledge that this whole workflow end to end requires just immense amount of collaboration, because if you think about who touches these patients, patient needs to get the angiogram and embolization. There needs to then be the interval MRI. Then in the operating room, we need to use the navigation to identify the areas that have and have not lost contrast, selectively biopsy them, separately send those specimens labeled to one of the collaborating pathologists. And so we have here, everyone on the neurosurgery side, the neuroradiology side, the neuropathology side involved, in analyzing these cases. So a lot of work from a lot of people, and I think some really promising and interesting results that hopefully will have a major impact on treatment of meningiomas going forward. I'll take a moment just to acknowledge another really exciting collaboration between the BioDesign team, including Dr. Pedersen, and the engineering team, the new vascular lab run by Dr. Berenstein, and our collaborators in nuclear medicine, including Dr. Munir Ghassani. We're working now on a novel embolic agent, which will include both the capability to embolize and devascularize the tumors, but also to provide primary treatment through liquid brachytherapy. So in this particular case, radioactive iodine, one of the most well-established radiotherapeutics, has been incorporated into the embolization material. So more on this in a subsequent presentation, but also super exciting project ongoing. And then in the last section, I just want to spend a few minutes talking about implications for this work on minimally invasive treatment or more minimally invasive treatment of meningiomas. I took a section out of this presentation that I included the last time we gave grand rounds on this 2 years ago, which is really lessons from middle meningeal artery embolization for subdural hematoma. And it's a whole nother conversation, but you know, the very favorable clinical trials that have come out over the last year discuss, implicating the role of middle meningeal artery embolization for treatment of subdural hematoma has implications for treatment of meningiomas. And there are many similarities, both anatomic and physiologic, between a tumor that takes its blood supply and grows from the meninges and a hematoma or an inflammatory or other response of the pachymeninges that also has shown a response to embolization, for which as we know, surgery also has a role. So a lot of parallels between these pathologies, and in that respect, I think we're going to have a lot to learn about how to implement trials in this area. But the two areas that I want to highlight are this question of can we perform keyhole resections rather than large open resections for some well-embolized meningiomas, particularly if they've undergone a liquefactive type necrosis, as Ian was alluding to. And second, are some meningiomas appropriate for standalone treatment by just embolization without the need for resection? So here's a case, a large right frontal convexity meningioma. You're seeing here the microcatheter injections used for the embolization. You could see the onyx cast on the far right of the screen following embolization. Here's side by side the preoperative MRI and the preoperative post-embolization MRI. So 1.7 cc's of onyx used, grade 3 devascularization, resulting in a 56% extent of embolization, significant reduction in tumor edema, a small but asymptomatic volumetric increase. Here, side by side, are the pre-op, post-embolization, post-op, and then 1 month post-op MRIs, all taken at the same level. So, and importantly, this is a case that Dr. Beddison resected after embolization. He was able to do this case through basically a large burr hole. Not to say that it was trivial, but you can see it was kind of that marshmallow fluff consistency, and that certainly facilitated a significant amount of debulking of the well-devascularized tumor through a much smaller aperture than would ordinarily be used for a 7 or 8 centimeter meningioma. And I think that's a theme that we should be able to move the needle on going forward. Finally, this question that I think many of us have been discussing over the last several years: is embolization alone without resection a viable option for some meningiomas? And Ian is in the process of a scoping review of the literature on this subject, and many of us have seen at the case report level over the years individual examples of patients treated for whatever reason with embolization alone. And definitely, of course, there's a bias to publish these cases, but definitely there is case reportable evidence suggesting that in some cases this may be a good idea. And on the backing of that, as well as our all the data that we've shown in the prior slides, we've now are almost at the level of institutional approval for what we're calling the EMBO registry, which will be a prospective registry of patients in whom it's deemed clinically appropriate to use embolization as an upfront treatment for meningiomas that are without the intention to resect. And this will primarily be restricted to patients who are on the elderly side, medically sick, or on anticoagulation that shouldn't be stopped before surgery, and for whom radiosurgery is not deemed optimal, for example, if the tumors are relatively large and not deemed suitable for radiation. And so these patients will be embolized and closely followed. And this will be, again, a large collaboration among the group of investigators involved in the other portion of the study. Very excited to see this move forward. And thanks again for having us here to discuss this work. Thanks to everyone who's been such effective collaborators, and I'm very happy to take questions.
spectacular work. Raj, you want to comment?
Sure, I'd be happy to. So fantastic work, Ben. I know that we've had these discussions over the years. Really fantastic leadership, organization. Um, you know, it's so amazing how we've become a national leader in the space, and that's really, as you emphasize, all the collaborative work that we've done, and the fact that as a department we have all the people who are motivated and interested in this space, and that takes a lot. It's not so simple to coordinate and do. These are the types of things that really work through understanding, communication, and leadership, Ben, and I compliment you on all that. Really fantastic. There's so many things about meningiomas that fascinate me, from a molecular level to a vascular edema profile. I think the embolization is in many ways an epiphenomenon of what we're seeing of behavior, whether that's really represented in an epigenetic space. Some of the things that I think are interesting is just, as you said, we're struggling still with those most complex skull-based tumors. And just as you've very nicely shown, it's hard to get meaningful embolization on exactly the tumors that are the hardest to resect. And of course, there are different, minimally invasive paradigms, endoscopically, et cetera. But I think beginning to understand that is going to be a challenge. And I think I have confidence we'll get there. But I think it's going to probably need much more creative understanding of embolization, anatomic pathways, vascular blood flow, et cetera. I think that the concept of edema is one metric to look at in terms of the effect of embolization. Edema, as we all know, is not just entirely vascular in its presentation. It's cytotoxic. It has other local inflammatory actors and so forth. So I think broadening that profile of how to look at tumor embolization, or just tumors in general, is going to be very important. We've done the same group of people you talk about, are the same people who've been working with me, and we've done a lot of the molecular understanding of some of this behavior. It's fascinatingly complex. For what we think to be a homogeneous tumor is actually very complex in its molecular profile, and I think that's well represented in the embolization work that you're going to see. And I just want to bring up one more thing that you brought up, which is that, we're going to continue to have to hold standards to the radiosurgery paradigm. It's an emerging high field that increases its indications. It's something that I think about all the time, obviously, as a skull-based surgeon. Am I holding myself up to the best case scenario and outcomes with radiosurgery? And I think that's going to be something we have to continue to cross-reference and analyze if we're really thinking about best outcomes. So just compliment you, Ben, on fantastic work.
Thanks. I want to just respond to just one. First of all, I want to say thank you, because many of the people who have been collaborating brought me into the department and have been incredibly supportive of this work, and that includes Dr. Pedersen and Dr. Vestava on the skull-based surgery side, and especially the senior cerebrovascular people on the IR side, including Jay and Johanna and Reed and Dr. Berenstein, and in particular for those very difficult, surgically difficult cases, especially, for example, the medial sphenoid wing or the clival and clinoidal meningiomas. That group, in the IR suite has been, I think, very carefully, but also, avant-garde and willing to carefully attempt catheterization of tumors that take their supply from the MHT or the ILT when it seems possible to do so. And so, it's just one of the things that we benefit from so much in having a really experienced, and technically sophisticated IR group. And so I did show a couple of cases. We breezed through them, but there were a couple of cases early on that were from Jay catheterizing, intradural ICA. And so I think as we better understand, and sometimes, those feeders are enlarged when just like in a vascular malformation. So, in a tumor, sometimes those feeders are enlarged. And so even though under normal circumstances, they wouldn't be catheterizable, the fact that they're supplying a tumor actually may make them amenable to embolization. And so I just want to say thank you to all the cerebrovascular folks who've been, so essential to moving the needle on this work.
Thanks, Ben. We're incredibly bullish on this. As you know, this was a big topic of conversation when we were just talking to Penn about coming here in the first place and joining our faculty. And you really ran with the ball. in a fantastic way. This is exciting. I think we have whole new paradigms of ways to consider and do things evolving, and that's what we're here for. That's why we're in academic medicine.
I really hope that there's going to be, an embo versus open debate about meningiomas evolving, as we move forward, as there is about subdurals and as there is about other, cerebrovascular pathologies. But I can certainly see it happening.
Ben, can I suggest something too? One thing that now that you have all this database is look at the venous drainage of the tumor, because in my long-term experience, when there was a cortical vein draining the tumor, it meant that the cortical invasion or participation. And I think that may be important as to the outcomes, Susan. Okay, as you're keeping the data, make them, even if it's got the middle meningeal injection and got just tumor and then drainage through the dura, noted. But if you find cortical, that's going to be a different problem. Okay.
Thank you.
Great.
Gotta pay
Great
attention
work.
to the venous side.
Yeah, not to mention the potential for transvenous embolization for those who meningiomas that can't be accessed transarterially. Ben, obviously a really important work. It probably doesn't need to be said because those of you who are here must realize this, but I hope you're realizing that you're seeing a renaissance of neurosurgery at Mount Sinai. What we've been doing and embolizing as neurosurgeons, meningiomas for many, many decades. But why is this advance happening now? It's some magic that occurs when you get a critical mass of creative people and a desire to push the needle forward. It's very deliberate. And when we started talking about this program, I was a little fearful that I would probably be seen as a bad person for pushing the envelope on non-surgical treatments. But as you can see, there's a whole science to this that is going to evolve and help our understanding as we go forward. I'm very glad that you took off with the idea that I think that I proposed to you in 2020 about image-guided, biopsy-driven differential biopsies of embolized versus non-embolized meningiomas. I think the concepts that Ian is beginning to look into are going to really advance the field. And I just would want to bring you back, Ian, and others, to the concept of measuring blood flow in the embolized and non-embolized portions of the tumor. Clearly, the extent of non-contrast enhancement on an MRI goes beyond the area of visible embolic material, as you pointed out. And you're trying to identify all kinds of paraphenomena to predict that. But that must have to do with blood flow reductions, which are measurable with tools that exist right now, whether it's microvascular Doppler or some other method that can be done. So I do want you to consider the intraoperative measurement of blood flow as a predictor of what you find histologically. And then for Ray, you mentioned and you've studied the incidence of major stroke, but I think Ian actually has a paper on the incidence of DWI hits after preoperative angiography in minimally invasive, I don't know whether it was subdural or ICH evacuations, Ian. It was one of your papers where you looked at the number of DWI hits in those patients, whether they had a pre-resection angiogram or not. Was that subdurals or was that ICHs?
Intracerebral hemorrhage, and it was led by Christina Rosita.
Right. That was one of her papers. But you need to do that analysis, Ray. You've got to add to that the DWI hits. Because if we don't talk about it, then it will come up as a criticism if you're just looking for major strokes. And finally, Ian, you should write up and do more of those we should do more of the keyhole cases, but you can write up that case as as part of the embolization type of protocols, the keyhole. As you know, Ted Schwartz is now written a whole book on transorbital keyhole resections of meningioma. So this area of surgery continues to evoke a lot of interest, and I'm sure you get some traction there.
I just want to say that I really think it's a testament to the strength and openness to research of the whole cerebrovascular program that we could even implement the post-embolization MRI. Many centers would not even let that move forward because the proceduralists don't always want their DWI hits to be counted and looked at, and that went on off without a hitch, and we've done it consecutively. Every patient has it now, and I want to say that says a lot about the program here, both the strength and the
Well, I think
openness
we should
to.
that's because of Mako. That's because of Mako, who is pushing this forward. I will say there's a little wheeling and dealing, though, because at the same time, I'm pushing the concept of embolization only. So the two go hand in hand. If you're going to get to test that concept, then we're going to make sure that we look at it in detail, right, Jay?